Hello, I am Saumi Tupal, a research assistant professor at SIU School of Medicine, and I'll be presenting you the results of our study that looked at novel approach for patient identification for screening high-risk patients for lung cancer. This study was conducted in collaboration with the departments of CT surgery, pulmonology, and family medicine, and Simon's Cancer Institute at SIU School of Medicine. Lung and bronchus cancer are the third most commonly identified cancer among all new cases of cancers and is the topmost cause of cancer-related deaths in the US. By looking at the state statistics, the rate of new lung cancer cases is 62 per 100,000, which is significantly higher than the national rate of 57. Illinois ranks 32nd among all states, placing it in the average tier. Over the past 5 years, the rate of new cases casually declined by 12%. The 5-year survival rate in Illinois is around 26%, which is significantly higher than the national rate of 25%. It ranks 18th among the 46 states with survival data, placing it again in the average tier. Over the past 5 years, the survival rate in Illinois has improved by 11%. In this graph, we can see the stage of diagnosis of lung cancer and the corresponding estimated 5-year survival. In Illinois, approximately 27% of cases were caught at an early stage, which is significantly higher than the national rate of 26%, as shown in the graph. The state ranks 17th among the 49 states with data on diagnosis at an early stage. Over the last 5 years, the early diagnosis rate in Illinois improved by 18%. We see a direct relationship between stage of diagnosis and the 5-year survival rates. The 5-year survival is longer in individuals with early stage diagnosis. Hence, it is key to identify lung cancer at an early stage. Currently, low-dose computed tomography has been approved for screening in high-risk individuals by the US Preventive Service Task Force. The current guidelines recommended for screening include all adults aged 50 to 80 years with a history of smoking 20-pack a year and currently smoking or quit smoking within the past 15 years. The decision to implement low-dose CT for lung cancer screening was based on a national lung cancer screening study conducted in 2011, which showed a 20% decrease in lung cancer mortality with annual low-dose computed tomography screening. In this graph, you can see the percentage of lung cancer screening from 2010 to 2015. Screening was consistent among men, and the screening rates actually improved in women over a 5-year period. By looking at the race distribution, screening among non-Hispanic whites steadily improved and was the highest in 2015, while there was a steep decline in screening among non-Hispanic Blacks, and a very low percentage of Hispanic population actually received low-dose CT during this period. In this graph, you can see the LDCT screening is low among individuals who live below the federal poverty level. These statistics clearly demonstrate the disparity in LDCT screening among certain race ethnic groups and among individuals living below poverty level. It is essential to identify the cause of these disparities and develop strategies to address these disparities. We conducted a pilot study to assess a proactive recruitment strategy for patient identification using Nurse Navigator and telephone pre-screening visits. We identified all individuals eligible for screening using the old USPSTF criteria that was available before 2021. So we included all patients 55 to 80 years, seen by 4 of our SIU family and community medicine faculty. The study was conducted in 2 phases. The phase 1 was a retrospective study where we screened all patients aged 55 to 80 years from our family medicine group. 4 physicians participated in the study, and we performed a chart review to identify eligible individuals who had screening in the past year and their outcomes. A total of 738 patients were seen by the 4 physicians in the age group. Of those, 287 were never smokers and excluded from the study. Of the remaining 184 patients, that is 41%, only 41%, that is 184 patients, actually had proper documentation of smoking data and were eligible for screening, of which 32 patients, that is 17%, actually completed the screening. And in 10 patients, that is 5% of the population, a lesion was identified. In the prospective phase, we used the same population of patients. The healthcare navigator proactively contacted these patients, assessed eligibility, and provided additional information about low-dose CT screening and smoking cessation. Willing patients were referred to one of their primary care physicians. If the patient refused, then the reason for refusal was documented. In the prospective phase, the nurse navigator was able to identify additional 12% of patients who had insufficient smoking history by contacting the patients by phone. Of the 206 individuals eligible for screening, 59% agreed to undergo low-dose CT screening and 15% declined. Though 122 patients agreed for screening, only 46% actually met with the provider and 16% completed low-dose CT screening, with 8% were identified with a lesion. Based on our study, we can see that around 45% of individuals were eligible for low-dose CT screening in the cohort. The willingness to get a low-dose CT screening was around 60% in our prospective phase, and 50% of the patients refused low-dose CT screening. Additional 12% were eligible for proactive assessment. However, only 46% met with the provider, and only 20% had low-dose CT prescribed. Proactive patient identification actually helped in identifying an additional 37% eligible patients for low-dose CT. The topmost causes for declining low-dose CT were no transportation and no time to schedule testing. Based on our results, our long-term goal is to establish a system to independently identify eligible patients for low-dose CT, get the low-dose CT screening performed and scheduled, further management with the help of nurse navigator using telehealth. The objective of our future plans are to identify eligible patients based on the USPSTF guidelines with the help of a nurse navigator, provide pre-screening counseling, and prescribe low-dose CT using telemedicine, schedule low-dose CT in an approved facility closer to the patient's address, follow up with the results of the screening with the patient within 48 hours of screening using telemedicine by the nurse navigator or the physicians with the help of a lung cancer screening clinic, and finally refer the patient for further management or schedule screening for the next year. Thank you.